Dr. Abdulaziz, is it Hiwat or Hiwat?
Hiwat.
Okay.
Hiwat darsane.
Okay, we can start.
Hello, everyone. My name is Sandy Romankis, and I'm the director of the Alive and Thrive Initiative. And I'd like to welcome you to the Alive and Thrive webinar on using school-based programs to improve adolescent girls' nutrition. Next slide. First, some housekeeping reminders. This webinar is being recorded, and the recording will be made available afterwards. The slides being used today will also be made available. If you would like to introduce yourself or chat throughout the webinar, please use the chat function that's circled on the bottom left. For questions, please use the Q&A function found towards the bottom middle of your screen. And you can type questions in throughout the webinar, and we will respond to these during the Q&A session at the end of the presentation. For simultaneous translation into French, please click on the interpretation button, which is also circled here on this slide, and that will move it over to translation in French. Next slide, please. Alive and Thrive is a global initiative that focuses on maternal, infant, young child, and adolescent nutrition. We've been working in Ethiopia since 2008, doing research with the government of Ethiopia and with our research partner, IFPRI. We also provide technical assistance on multi-sectoral nutrition programming that targets the mycin groups through food, health, social protection, and education systems. This webinar is going to focus on our implementation research in Ethiopia on using school-based programs to reach adolescent girls with nutrition interventions, including the rationale for the study, the intervention design, the results of the study, and subsequent adaptation and scale-up. We will have time for Q&A after the presentations of our 6 distinguished speakers. Next slide. Today with us, we have Dr. Purnima Menon, who is a senior research fellow at IFPRI. She is going to give us an overview of why testing new research interventions for adolescents is important and how this research from Ethiopia expands on the Lancet series. Dr. Tina Sangvi is an Alive and Thrive senior advisor for mycin, and Tina is going to provide the background on Alive and Thrive's approach to the intervention design. Tamara Walisa is a technical associate director with Alive and Thrive in Ethiopia, and Tamara is going to lead us through how the interventions were implemented as part of this research. Dr. Sunny Kim is a research fellow at IFPRI. She was also the principal investigator for the study, and she will present the results of the study. Dr. Abdulaziz Ali Umar is the Alive and Thrive Ethiopia country director, and he is going to cover the next steps for scale up of the interventions in Ethiopia. But first, we were hoping to have an honored guest, Hiwat Darsane, with us today from Ethiopia, but it looks like her connection is not working. So we are going to go to Plan B, which is a pre-recorded message from her. And Hiwat is the lead executive officer for the National Nutrition Coordination Office of the Ministry of Health in Ethiopia. And she earned her bachelor's degree from Hawassa University in public health, and her master's of science from the University of Gondar in applied human nutrition. She has more than 16 years of experience working in public health at many levels, including as a regional gender advisor at the SNNPR Regional Health Bureau. For the last 8 years, she has been with the Ministry of Health, and she is going to lead us off with a few words about Ethiopia's commitment to multisectoral nutrition. Diana, over to you for the recording.
Ladies and gentlemen, over the last 20 years, Ethiopia has made significant progress in reducing undernutrition among children and mothers. Between 2000 and 2019, the prevalence of chronic malnutrition, which is stunting, decreased from 58% to 37%. During the same period, the proportion of underweight children decreased from 41% to 21%, and the proportion of wasted children decreased from 12% to 7%. Among women of reproductive age, 8% were overweight or obese, and 24% were anemic, and 22% were teen, based on 2016 Ethiopian Demographic and Health Survey. Additionally, among adolescents 15 to 19 years old, thinness, stunting, and obesity rate were reduced to 29, 15, and 11.3% respectively. Ladies and gentlemen, over the last 20 years, Ethiopia has made significant progress in reducing undernutrition among children and mothers. Between 2000 and 2019, the prevalence of chronic malnutrition, which is stunting, decreased from 58% to 37%. During the same period, the proportion of underweight children decreased from 41% to 21%, and the proportion of wasted children decreased from 12% to 7%. More than 58% of teenagers get married before they turn 18 years old, which raises the risk of unfavorable pregnancy and birth outcome and worsens the cycle of malnutrition. Ladies and gentlemen, the Ethiopian government is committed to end all forms of malnutrition by making good nutrition as a policy priority. In support of this goal, the Ethiopian government has developed and implemented various food and nutrition-related policy documents, including the Food and Nutrition Policy and its Strategy, the Sekota Declaration 15 Years Roadmap, the Adolescent, Maternal and Infant and Young Children Nutrition Guideline, the Adolescent Nutrition Implementation. Of course, it is a draft one, in Ethiopian Food System Roadmap, and other nutrition-sensitive strategies and programs among the lists. The government 10 years development strategy plan has prioritized reducing stunting among children under the age of 5 years is to reduce to 13% by 2030. Ladies and gentlemen, a strong national commitment involving and collaborating with multiple sectors is driving improvement in adolescent, maternal, and child nutrition status. Food and nutrition coordination platforms have been established and are in operation at the national and regional levels, bringing together food and nutrition strategies, implementing sectors, UN agencies, donors, civil society organizations, private sectors, and academia, in general, all actors. These platforms are essential for effectively coordinating all relevant actors to implement national food and nutrition policies, strategies, programs, and projects at all levels. Food and nutrition development partners are among the key players contributing significantly to noble cause of combating malnutrition in all its forms and manifestations. Ethiopia's government and health sector express gratitude for their ongoing assistance in implementing the food and nutrition strategy. One of the strategic objectives of food and nutrition strategy is evidence generation and utilization and aggressive engagement of the government in its development partners in generating up-to-date data on food and nutrition is required to ensure evidence-based decision-making. I hope that today's FHI 360 Alive and Thrive project dissemination of research on improving adolescent girls' dietary practice in Ethiopia serves as an example of how government and partners collaboration can result in desired outcome of improving community adolescent and maternal nutrition status and strengthening public health and nutrition service delivery system in the health sector. Finally, I would like to express my gratitude to Alive and Thrive and its donor, the Bill and Melinda Gates Foundation, for their significant contributions to maternal and adolescent nutrition, as well as their overall support for strengthening food and nutrition ecosystem. So having said this, invest in nutrition for national development. Thank you very much. Wishing you successful learning forum. Thank you.
Thank you. Well, we really wish that Hiwa could have been with us today. We're just happy that we were all able to hear her voice and to hear her comments in the commitment of the Ethiopian Ministry of Health to adolescent nutrition and multi-sectoral nutrition. And I think some of her comments provide a great segue to our next speaker, who is Purnima Menon. And Purnima conducts implementation research on scaling up maternal and child nutrition interventions, including large-scale behavior change communication programs in nutrition and health. And as I think a lot of us know, she publishes extensively. And she's going to talk to us now about reaching adolescent girls and young women with effective interventions. Purnima, over to you.
Thank you so much, Sandy. It's a great pleasure to be here today to connect the dots between the work that was done on the Lancet series and the intervention and the results that we'll hear about today. What I plan to do today is just give you a very brief snapshot of the kinds of things that we examined in the Lancet series. The series was published in November of 2021. And what I hope it does is really, set the context, the evidence context within which the findings of the Ethiopia work done by Alive and Thrive, really add and contribute to the global literature. Could I have the next? Sorry, I should acknowledge, all of the partners and co-authors on this series, and also offer this as a tribute to George Patton, who we lost a few months ago. George led a large team of us through the development of the series, and we're just really grateful for his inspiration and support. And this is a mission that deserves to be continued. So I do want to acknowledge that. On the third paper itself on the series, it was co-led with Dougal Hargreaves and Emily Mates. And we had numerous co-authors from around the world, especially showcasing insights from India and China in the series on programs and policies, which I was also one of the lead co-authors on. Okay, next, with that introduction, next slide, please. So the first paper in the series, which was led by Ed Sangello and Shane Norris, really made the point of the critical importance of nutrition in the context of adolescence. This is just a one-slide summary of the incredible research they brought together from really diverse data sets and diverse bodies of literature that really helps to highlight that in that period of adolescence for human beings, every single system changes from physiological to to physical, mental, and everything. And what they were able to highlight with the series is the key importance of nutrition in supporting the growth, development, and maturation of those physiological systems. Next slide. The second paper in the series, which was led by Lynette Neufeld, really focused in on adolescent diets and food choices. And we're going to hear a bit about that in both in the context of the interventions and the research results today. And it really made the point that, three sort of really critical points. Firstly, that nutritious foods were insufficiently accessible to adolescents around the world. It also highlighted how adolescents were affected by, the marketing and the preponderance of the availability of unhealthy foods around them, and by the social norms of food consumption. So one of the things that this particular paper did was really to highlight how different aspects of individual autonomy, agency, and the environment that shapes food choice and dietary intake comes together to shape what happens in how adolescents access food. And we'll hear some insights around that from the results that Sunny will present later in terms of what the interventions were able to nudge and what was more challenging. Next slide, please. Now, the last paper in the series focused on interventions. And through an extensive review of interventions across the global literature, we identified sort of three areas for critical focus, which is that interventions must focus ideally on all forms of malnutrition. And this is where the insights on diets especially comes in. Second, that ideally interventions should be able to both improve the food and nutrition environment and increase individual agency. And I think we'll see this in the studies and the efforts of I don't want to sort of reveal anything much, but the importance of this interplay of the food environment and individual nutrition agency will I think will be quite prominent in what we see later on. Next slide, please. One of the things that we really wanted to emphasize in the context of closing out the series was just how critical it is to invest in improving adolescent nutrition. It offers a tremendous opportunity. We're in a world where nutrition transitions are really changing what's happening for young people globally. And the efforts to improve adolescent nutrition are just really crucial in this context because they provide that opportunity to shape the health and well-being of this generation. We especially highlighted in the series the importance of school-based platforms to test and trial different types of interventions. There have been a few interventions which we highlighted, in the series, but they were really few and far between. And so one of the things that we called for in the series is really whole-scale attention to evidence generation and using critical platforms like school-based platforms because they reach so many adolescents around the world. And we really wanted intervention designers and program implementers and researchers to come at this with the idea that multifaceted interventions that engage and support individuals and reshape the environments in which they access their food are really super important, and that schools offer opportunities for both of those at very vulnerable age groups. Next slide, please. And I think that will be probably my last. I'll end with this. We have seen great successes in the world of climate change with the engagement and really the enthusiasm and innovation of the youth. And it is really critical for us to acknowledge that food and nutrition are set in this broader ecological, social, and a deeply political context. And what we really need to see through multiple types of interventions is how we can support youth themselves to engage in shaping their future while not shirking away from the responsibilities that the adults in the room have. So with that, I'll hand over to Sandy. The series is, as I said, is available and has been out there for people to read, but I'm really excited to hear more about the interventions and the research results. Thank you again for the opportunity to share the series with you all today.
Great. Thank you so much, Purnima. That was really great. And thank you especially for that emphasis on the importance of youth engagement. I think that's something that we really need to keep considering as we roll things out in different countries. Our next speaker is Dr. Tina Sangvi. She is the Senior Advisor for Alive and Thrive on maternal, infant, young child, and adolescent nutrition, Tina, I'm going to turn the microphone over to you now. Thank you.
Next slide, please. Good day, everyone. So this is the overall program timeline for our project, for the study. We started in 2017 with a situational analysis, a year following the issuing of the National Adolescent Nutrition Guidelines by the government. And this was followed by several steps in formative work that was done to identify the priorities, the priority behaviors, the platforms through which we should work, the barriers and facilitators of the priority behaviors that we were going to focus on, and what were the drivers of behavior change and who all should be involved. So there was an extended period of formative work that needed to be done. And this then transferred over to implementation and the evaluation, and now we're in the middle of scale up. So our presentation follows this timeline roughly. So I'll go through the initial part of intervention design and hand it over to our colleague Tamarat from Ethiopia for the implementation and the operational design, which was crucial for the success of this program. And then we will hear from IFPRI on what the results were. And our team, our director from Ethiopia, will go through the scale up and plans that are being led by the government of Ethiopia. Next slide, please. So the goal was to identify and address implementation knowledge gaps. This wasn't about trying to prove yet again that adolescent nutrition is important, but rather how do you reach them? What is the most sustainable and effective way to bring about change that is so urgently needed? And we wanted to develop and test the feasibility of interventions in the different platforms that are needed to bring about change. The focus was on the younger age group of adolescents. We could have covered the entire 10 to 19-year age range of adolescents, but we decided to focus on 10 to 14-year-olds. This is where the needs and the deficits begin to accelerate. This is where we can reach them more easily, because in Ethiopia, most girls are enrolled in primary schools. So it's much easier and faster to scale up. This is also the age where behavior change is more easily achieved. They're forming their attitudes and their beliefs about what they should be consuming and what this means. And in the next slide, we can see, yes. So another reason for focusing on nutrition in primary schools was that it was already part of the government school curriculum. And we wanted to enhance that and to achieve results there was the intention of bringing about nutrition improvement with schools being a primary player in this. So the gaps and opportunities that were identified through the formative studies, as you can see on the left-hand side, 3 primary behaviors, 3 priority behaviors were identified based on data and need. 27% of girls only were achieving minimum dietary diversity. And meal frequency was really low. On school days, adolescent girls were only consuming, on average, 2.3 meals. But over 60% reported that they were consuming unhealthy foods every day. So the evidence was strong in terms of the health impact and nutrition impacts from these behaviors. There was strong evidence that these are really going to make a difference if we could improve these. And the opportunities were there. Again, our formative work showed that we can address this, even though there are barriers, even though it's not easy, but it is still possible within the existing context. The next slide, please. So this shows an example of how we came about focusing and filling in the contents of the intervention. So once we knew what the 3 priority behaviors were, now we have to dig in and find out what the facilitators and barriers are. So here are some of the examples. The multivariable analysis of our baseline showed that the variety of foods available at home would be a major factor. We needed to address that. nutrition knowledge of adolescent girls. We needed to address that. That was significantly associated with their behaviors. Our desk review reinforced what later was published in the Lancet about having multiple socioecological influences in the context. It wasn't just the adolescent girls, but we needed to engage important and influential people from the environment around the girls in order to bring about change and enable them to practice what they were going to learn through their knowledge improvement. Then that's not enough. Even how do you address facilitators and barriers so that there's actually a change? So these, all the theories of behavior change very often converge on these four factors. There has to be knowledge, there has to be beliefs, there have to be social norms, and there has to be self-confidence in the girls. The next slide, please. So this is identifying the influencers that needed to be engaged in the program. So I will hand it over to my colleague from Ethiopia, Tamirat Walesa, who will take us through the further development of the program implementation, our operations, and lessons learned from implementation. Over to you, Tamirat. Thank you.
Thank you, Katrina. Hello all. So we implemented our program in two distinct socio-ecologically different regions. Southern Nation Nationality region to represent the agrarian context in Ethiopia, and the Somali region to represent the pastoralist context in Ethiopia. So the Wareda selection is, the region selection is made in consultation with the federal and regional, Federal Minister of Health and Regional Health Bureau. Next slide, please. These are the three critical behaviors that was selected based on the gaps and health and nutrition consequence, as well as room for improvement. So the behaviors that we were focusing were diversity, male frequency, reducing the consumption of unhealthy food. Next slide. These are the four program messages we promoted using different formats. So the first series are linked with the three critical behavior, and the fourth one is the one which is focusing on maintaining healthy body weight for height and age. So these are the message we were focusing on. Next slide. So to design the program, we employed different approach. Particularly, operational details were developed through participatory co-designing process involving key actors as well as adolescent girls and their parents. So the co-designing process enabled us to identify or to refine the roles and responsibilities of actors which are selected from the three identified platforms, and as well as their training need or the capacity building need, materials, and so on. So overall, the aim of the program design was to achieve repeated exposure to key message for all school-going adolescent girls. Next slide. So the school or the education platform was identified as a key delivery platform. So from this platform, 6 core school-based contact points were identified. So one of the contact points identified in the school platform was in classroom discussion. So biology or social study or social science teachers were supposed to hold a Q&A session with focusing on a certain topic of adolescent nutrition. So after the discussion, they usually ask the adolescent girls to continue or to extend their discussion just to discuss with their parents as well as with their peers. So the other contact point that was identified in the school was the flag ceremony. So in Ethiopia, every morning that the students come to the point where they rise the flag. So that contact point was proposed to be utilized by school principal. So that contact point where the flag ceremony was one of the contact points utilized to promote as well as reinforce adolescent nutrition message. So the peer mentorship group session was organized because of the co-designing process, and the peer mentorship under the supervision of trained teacher, peer leaders come together. The peer leaders come together and under the peer leaders, 5 to 6 adolescent girls sit and discuss about their nutrition. So the peer mentorship session is a kind of a group session that provides a space for girls to discuss about their nutrition, their achievement, the challenge, and so on. So the other one is a club session. So there are a number of clubs in schools. So the schools propose relevant clubs that can fit to integrate adolescent nutrition promotion, so that the school club is also utilized. The quarterly BMI measurement and counseling session was the other session or intervention integrated to the school extracurricular activity. So the trained teacher hold a quarterly BMI measurement, interpretation and counseling session. So this is one of the contact points. So the last one was in the school there is parent meeting that is happening regularly, where the schools discuss about their, especially teachers discuss with the parents about the school performance of kids. So this, based on the co-designing, the school management was able to integrate adolescent nutrition agenda in their discussion topic. So there are other reinforcing contact points. Adolescents were sent with message to their parents, health extension workers, or utilizing their different contact with their parent to promote or reinforce adolescent nutrition message. And the community contact and was also utilized, and school premises also considered to display message. Next slide, please. So user-friendly, need-based, audience-specific SBCC materials were developed, and these materials were continuously adjusted based on feedbacks and based on feedbacks from each audience. Next slide. So as a system strengthening component or intervention, we developed protocols specified for each actors to deliver adolescent nutrition intervention. So these protocols were developed. The other thing is ongoing capacity building and coaching were provided for school teachers. So to strengthening data use capacity, frequent supportive supervisions that employed observations, record review, and interview with provider were carried out. So particularly when we manage the support supervision, we were holding a discussion with the provider as well as adolescent girls and their parents. So we were asking them about their, especially from the provider end, the utilization in relation to contact point, materials, and so on. And we cross-check with adolescent girls. So this activity enabled us to identify gaps. And that enabled us to make an ongoing adjustment. So the other thing is we used routine monitoring data to provide feedback, in addition to the supportive supervision findings. And we also conducted a midterm assessment that significantly helped us to make a number of or measurable adjustment to our intervention. Next slide. So we employed flexibility and ongoing monitoring and adaptation to the changing school, environment in school to fill recurring gaps identified through monitoring and supervision and to work around the session. So the other thing is COVID-induced school adjustments such as modification, particularly in shortening of school recess time and the school session, that forced us to engage more teachers in the retraining session, to employ frequent coaching and supervision, and to hold additional review session. Next slide. So the program lesson, school actors require continuous capacity building and follow-up. And SBCC materials should be very brief and focused on need. So we need to check whether the audience are using that materials. We need to get the reflection continuously to make, based on that reflection, we need to make an adjustment to the materials as well. Teachers have the credibility to motivate adolescent girls as well as their parents to improve their diets. So as I mentioned earlier, ongoing modification will be needed to adapt changing environment in the school. So this is all from my end. So our next speaker is Dr. Sani Kim. Dr. Sani, please.
Thanks, Tamrat. Good morning, good afternoon, and good evening, everyone. I'll be presenting on the findings from our study on the feasibility of integrating nutrition interventions into the school-based platforms and the impacts on adolescent girls' diets. Making this presentation on behalf of our research teams at IFPRI and at the Addis Continental Institute of Public Health in Ethiopia. Next slide. For our study, we had two main questions. Is it feasible to integrate nutrition education interventions into existing school-based platforms? And two, what are the impacts of these interventions on the diets of adolescent girls? Next slide. In terms of the evidence on integration, I'll present some findings on exposure to training and materials, supervision of school staff, staff knowledge about nutrition, and exposure to the interventions among adolescents and their parents. To answer the question on effectiveness, I'll present our study results on outcomes of dietary diversity, meal frequency, and consumption of unhealthy foods, including sweets, fried and salty foods, and sugar-sweetened beverages among adolescent girls. Next slide. So Tamrat presented already on this, and I'll just give a quick overview that there were 6 school-based platforms through which nutrition education or messages were delivered. That's weekly, the flag meeting ceremonies, the weekly classroom lessons, student clubs and peer mentoring, and BMI measurement counseling, which is only held just once in the semester, and monthly parents meetings at schools. There were 4 promoted behaviors with their key messages shown here again on dietary diversity, meal frequency, and making healthy food choices or avoiding junk foods, and to a lesser degree of intensity on maintaining a healthy body weight. Next slide. You've also seen this timeline shared by Tina, but I'll focus on the research study timing itself. In late 2019, we conducted a baseline survey, and this program slowly started to roll out training and disseminate training program materials. But in March 2020, as Tamrat also mentioned, the first case of COVID-19 was discovered in Ethiopia, and the government of Ethiopia declared a state of emergency, and all schools were closed for the rest of the school year. And the adolescent nutrition program was halted for about 7 months in the field, although there was a lot of internal meetings and planning going on at that time. Then in October, schools were reopened and classes resumed. The Alive and Thrive team restarted training of school staff and working with staff and others to implement the interventions. And about after 4 months or 1 school semester, we conducted a full online survey. Next slide. We designed the study as a cluster randomized program evaluation. A cluster was a primary school that includes grades 1 through 8 in 2 regions, SNMP and Somali. These regions are challenging to work in, but they were selected with the government of Ethiopia to include different contexts with both agrarian and pastoralist livelihoods. 54 primary schools across the 2 regions were randomly allocated into the 2 study arms, the intervention and control. And in the control schools, there were no nutrition-specific activities aside from the standard academic or school curriculum. In 2019, we conducted a baseline survey at the school level, but included about 1/3 of the estimated sample size at the household level across all the clusters due to resource constraints. And the baseline data was used to assess balance and comparability between study arms and was really focused on informing intervention design. In 2021, we conducted an inline survey with the full sample size, which is indicated here in the table on the right. We interviewed 536 adolescent girls aged 10 to 14 years who were enrolled in the grades 4 through 8 in the study schools, and their parents, as well as the school principals and main science teachers who were expected to deliver the interventions. We also conducted school assessments in terms of their operations and environment. We used the full inline survey data only to estimate impacts at the individual level between study arms. Next slide. For the impact estimates, we used an intent to treat specification where all the participants in the assigned study arms were included and analyzed according to their study arm, regardless of whether they received interventions or not. We estimated intervention effects using linear regression models for mean differences, clustered at the school level and controlled for covariates, including the adolescents, girls' age, region, household food security, and wealth. We also conducted robustness checks using difference in different method for outcome variables available at the baseline and end line, such as on dietary diversity outcomes. We also analyzed the plausibility of our results by examining the outcomes along the program impact pathways, from service delivery to exposure and behavioral determinants. Next slide. Okay, now for the results on integration and implementation of the interventions. Next slide. As we might expect, most of the school staff in the intervention schools, which included the principals and main science teachers, reported having received training on the topic of adolescent nutrition in the past year, particularly within the past 3 months prior to the inline survey. And nearly none of the staff in the control schools reported having received any training related to nutrition for adolescents. Next slide. From the school assessments, we observed that nearly all of the intervention schools displayed in the Alive and Thrive posters with its key messages in the school records, more intervention schools also kept records of the nutrition education activities conducted, and with parent meetings, about parent meetings. There were no real differences compared to the control schools on other records, such as on school management or any community events or activities at the school. Next slide. In the education sector, supervision is quite systematic and routinized. We observed no difference in the frequency of supervision, which was usually monthly and continued to be done so in both the intervention and control schools, or the source of supervision, which was usually done by the district education officers and school leaders. But as seen in the bars in the far right, more staff in intervention schools reported that in the last supervision conducted, it included checks and reinforcements on nutrition activities. This was also by design, as Tamrat also mentioned, since the adolescent nutrition program incorporated checklists within the supervisor's routine work and try not to create separate supervision lines in parallel. Next slide. As shown here, school staff had pretty high knowledge about nutrition topics, particularly examples of nutrient-rich foods and the benefits of different food groups. Still looking across all of the 14 knowledge items in a summative score, and particularly on knowledge about naming at least 5 different food groups or on dietary diversity, we observe significantly higher knowledge among staff in the intervention schools. Next slide. Then as a result, we observed high exposure to the different interventions reported by adolescent girls, and more than half of the parents reported attending school meetings where nutrition was discussed. But as also Tamrat mentioned, that adolescents were encouraged to share what they learned with their parents during these activities. So parents were expected to hear about nutrition through their children also. And in the far right, you can see that nearly 95% of the girls or parents in the intervention schools reported being exposed to at least one intervention. Next slide. So now, what were the impacts of the interventions on adolescent girls' diets? Next slide. Okay, so here I just present some characteristics of the adolescent girls, parents, respondents, and their households at baseline and endline. Again, the baseline being a much smaller sample, but at baseline, the study arms were balanced on the main outcome variables. Tina also mentioned that dietary diversity was low at 3.7 food groups out of 10, and about 60% of the adolescent girls consumed junk foods in the previous 24 hours. At endline, we observed that more households in the intervention areas were food secure and had higher wells. So we really controlled for these variables and conducted subgroup analysis to check for any differences in effects on outcomes and observed that our results held up. Next slide. So for dietary diversity, we saw a large intervention effect of about 1.3 food groups among adolescent girls. At endline, dietary diversity score was 5.4 food groups out of 10 in the intervention areas and 4 in the control areas. And here in the figure, we show that 67% of adolescent girls in intervention schools consumed at least 5 food groups in the previous 24 hours and had over 5 times higher odds of achieving minimum dietary diversity or consuming, again, at least 5 food groups compared to those in the control schools. And there were higher odds of consuming several different food groups here shown below, such as nuts and eggs and fruits. Next slide. At N-Line, adolescent girls in intervention schools also had a higher meal frequency by nearly 1 meal or snack time. That's out of 6 total times. And this was contributed by eating breakfast and snacking in the mid-morning or at mid-afternoon times. So not in necessarily the solid meals at lunch or dinner, but during mostly the snacking and breakfast. Next slide. But for consumption of unhealthy foods, we observed no impact on overall consumption of junk foods, which was still consumed by about half of the girls in the previous 24 hours. Although we did observe that girls in intervention schools had lower odds of consuming sweets, such as candy and chocolates, compared to the control schools. Next slide. In conclusion, our study showed the feasibility of integrating nutrition education interventions into school-based platforms, even in a relatively short implementation period that we consider for about 4 months or one school semester. Providing and reinforcing the nutrition messages to adolescent girls and parents resulted in improved dietary diversity and meal frequency. But these interventions were not effective in curbing consumption of unhealthy foods. We considered that other strategies that address food environments, such as providing or placing perhaps nutritious foods or snack options at or near schools, are likely needed to influence adolescents' food choice on consuming junk foods. In terms of next steps, as well as a research priority, we will examine factors influencing adolescents' dietary behaviors by examining the influence of home and school food environments, parental control and interaction, as well as other behavioral determinants. More evidence about how adolescents make their food choices and testing ways to promote healthy food choices are really greatly needed, as Purnima really presented this session, opened the session with on these points. Next slide. Finally, I'd like to thank all our study participants and staff involved in the study, research work by our IFPRI team and ASIF team in Ethiopia. And I want to add here Dr. Ed Frangillo from the University of South Carolina. Excellent program work by Alive and Thrive in Ethiopia and headquarters, and funding from our donor, the Bill and Melinda Gates Foundation. Thank you. And now over to Dr. Abdulaziz.
Thank you, Sunny. Hello, everyone. I think we are coming closer to the end of this webinar session. In the next 15 minutes, I will be trying to summarize our overall process of adapting and scaling of these adolescent nutrition interventions. Just to give you a brief background on our work, when we started our adolescent nutrition implementation back in 2019, we had like 3 major objectives on this area. The first objective was to really develop and test the feasibility of adolescent nutrition interventions in schools and other community platforms. And the second objective of this implementation was to adapt and scale up these interventions to additional regions. And the final and third objective of our implementation was to ensure sustainability through government-led expansion. So to achieve these objectives, Alive and Thrive had divided the interventions into 3 phases. The first phase, where much of it has been discussed earlier, was implementation research phase, which was conducted during 2019 to 2021. And the second phase was the initial adaptation and scaling up phase, which was mainly led by Alive and Thrive and occurred during 2021 to 2022 fiscal year. And the third and the current phase is a government-led expansion. Next slide, please. So just to see the different behaviors of these 3 phases, the first phase was the implementation research phase, and this phase was an evidence generation phase, and it was a full implementation phase as it was an implementation research. So it was implemented by the school, and Woreda level implementation were fully implemented by local implementing partners from Terapeza Development Association in Southern Nations and Islamic Relief in Somali region. Enliven Tribes' role during this region was mainly providing technical assistance to the local implementing partners as well as the government technical people. In addition to these areas, during this phase, to ensure the quality of the implementation, entity collected, monitored, and analyzed data and used for decision making. In addition to these things, we conducted the baseline, midterm, and inline evaluations. As you heard earlier from Sunny, the baseline and inline evaluations were conducted by our research partner, IPFRI, but the midterm assessment was an in-house type of assessment, and mainly we used the results of the midterm of assessment to fine-tune some of our program activities. After we got the inline evaluation, we conducted an inline result dissemination workshop, both nationally in Addis as well as in the two regions, with the aim of disseminating the results to at national level, and also get buy-ins from the government, both at national and regional level, to make sure or to ensure adolescent nutrition is also included in the plan. In addition to the implementation regions, we also invited the planned new regions from Amhara, Oromia, and Afar to be this inline result dissemination workshop to share the results of this intervention. And finally, we developed materials and briefs on lessons learned during this phase. So during this phase, we were able to conduct or implement this adolescent nutrition in 59 schools in SN and PR and Somali region. Next slide, please. So the next phase was the adapting and scaling up. Actually, mainly this phase was also led by Enliven Tribe, and our engagement, Enliven Tribe's engagement here was mainly providing much technical assistance. So we had to, scale up to the new regions of Amhara, Afar, and Oromia. We need to adapt the results into these regions. And as you heard from Sunny's presentation, one of the key behaviors that did not show improvement during this implementation was
looks like our speaker is frozen.
Somali and SNNPR. Oh.
We can hear you now, Dr. Abdulaziz.
Can you hear me?
Yes, we can hear you now.
Sorry, it was a connection problem. So I don't know, maybe so. At this time, what we did was to conduct a consensus building workshop to understand why that key behavior was not observed. So we did consensus building workshop and developed a strategy to improve on that area. One of the things that came up during those consensus building workshops was the need to work on the school environment that we did. And the other important thing as part of adapting to the new regions was to streamline and contextualize the social behavioral change communication materials to the three new regions reality. And we did that one. And as we were the major technical assistant provider partner, we provided support to training, support supervision, and review meetings planned for expansion of these regions. And Enliven Tribe also used different platforms of school and health meetings to advocate for adolescent nutrition to be incorporated into the government's plan. Next slide, please. And we also did a sort of demand generation activity to the regional government officials. So we invited site visits by the regional officials, especially from education officials, to showcase what adolescent nutrition implementation look like and how simple it is to really incorporate it into the system. So following this lessons learning or experience sharing visits, regional bureau officials wrote or sent circulars or guidance to Waradas and schools to incorporate adolescent nutrition to their annual plan. So during this phase, we were able to add additional 71 new schools in 3 new regions and 2 controlled Waradas of Somali and SN and NPR region. Next slide, please. The third and the final phase of our implementation was the government-led expansion phase, which we believe is a critical phase for sustaining the impact of sustaining the impact. And during this phase, our support was really, our technical assistance support was limited, and the lead was the Regional Bureau of Education and schools. So during this phase, in addition to the contextualization we did in the previous phase, to make sure that they are easily accepted or easily managed by the regional governments, we did a sort of simplification of behavioral change materials and tools during this process. And one important thing that demonstrated the commitment of the government during this phase was the cost sharing scheme. So the government and regions were able to allocate some budget to support the trainings, some review meetings, and support supervision activities to scale up this phase. So in addition to the subnational or regional level commitment ownership by the government, Alive Tribe worked at national level to incorporate some of the lessons learned during this intervention to the Adolescent Nutrition Implementation Guide, which is on the final phase of development. Next slide, please. Sorry, so during this phase, we were able to add some additional 280 schools in these 3 regions and to the control orders of the existing regions. For one final thing we did actually mainly to convince or to support the regional governments to have some idea on the cost of adolescent nutrition per school per year. So we did a sort of cost analysis mainly. This is not really a typical financial or economic analysis. Rather, we did a sort of program-related cost analysis. So we included like budget for local implementing partners, developing and designing social behavioral change materials, training costs, support supervision costs, and review meeting costs were including this assessment. So the objective of this cost assessment government-led expansions would be much easier and much cheaper than either full direct implementation, which we did during phase 1, or partner-supported implementations, which we did in phase 2. So as you can see, in the first phase of implementation, the cost we incurred for a school for a year was more than 4,600 USD. But during the second phase, where LDT was providing technical assistance without direct implementation, was just above 1,000 USD, which was just 25% of the first phase or the implementation research phase cost. And the final or the government-led expansion phase was just above 400 USD or greater than 21,000 Ethiopian per school for a year or 1 school year period. So you can see how the cost will be significantly dropping if an intervention is done through the government platform, and if the government takes the major role on the leading interventions. Next slide, please. So then what? We have got these interventions, these results, this analysis. So our next plan is the first next plan way forward is we are planning to conduct a situational analysis mainly to synthesize evidence on improving adolescent nutrition across different contexts that include in and out of school adolescents, young and older adolescents, 10 to 19 years, and possibly urban and rural adolescents. And with this situational assessment, we have also a plan to assess factors influencing success of adolescent nutrition interventions. These interventions may be somewhat localized or widespread interventions or interventions led by government or other partners. The other area which we are dwelling now is there is an initiative from the Ministry of Education to incorporate nutrition into the biology subject in high school. So 11 Tribe is working with other partners to support the Ministry of Education to incorporate this one so that we will have the impact sustained through the process if we are able to incorporate to the school system. So this is what I have. I think the next will be Q&A. So over to you, Sandy, please. Thank you.
Great. Thank you so much, Dr. Abdulaziz. And thank you to all of our speakers for sharing the details on the research, the interventions, and now the transition to scale up to the government of Ethiopia. So we're going to move on to our Q&A panel. We have roughly about 25 minutes for that. I think all speakers should turn their cameras on now. We have some questions that have already come in. And just as a reminder, if anyone else would like to ask questions, please add them to the Q&A box at the bottom of the screen. And we're going to get started right now. And Tina, I'm going to start off with you. A question came in asking, were any supplements like IFA or multiple micronutrient supplements provided in the intervention?
So yes, we considered that very carefully, and we discussed it with other stakeholders, and our country team also explored the possibilities. But with the budgetary restrictions and with the current policies and regulations regarding distribution of supplements through schools, this was not possible. So we really had to limit it to nutrition education, counseling, and building an enabling environment. Over.
Great. Thank you, Tina. Sunny, I have two questions for you. First, how is minimum dietary diversity and consumption of unhealthy foods measured among the adolescents 10 to 14 years old?
Thanks, Sandy. Yeah, so the self-reported diet consumption module at the start of our was added in the start of the interviews with adolescent girls before asking about anything else in terms of exposure to interventions or knowledge. So it is self-reported. The adolescent girls were asked about consuming each of the 10 food groups during the day and night in the previous 24 hours using a list-based methods. And this also included local food examples from the diet quality questionnaires adapted for Ethiopia. Then the minimum dietary diversity, or the proportion of girls who consumed at least 5 out of the 10 food groups, was calculated. And although the minimum dietary diversity is a proxy indicator for higher micronutrient adequacy for women 15 to 49 years of age, we applied this indicator for our study sample of girls in the absence of a specific indicator for this age group. In terms of junk food consumption, we included 4 categories of junk foods, which I shared on baked sweets and other sweets, fried and salty foods, and soda and sugar sweetened beverages, and also items, examples that were adapted from the diet quality questionnaire for Ethiopia. And really, we took, in 2020, there was a published work of Joanne Arsenal and her colleagues on validation of 24-hour dietary recall among adolescents. This was in Burkina Faso, but really reporting that adolescents were able to self-report pretty reasonably on their diet. So we had them self-reported. Over.
Great. Thanks, Sonny. You actually answered the second question too about self-reporting.
I saw that.
Okay, figured. So I'm going to move on to Tamara then. Tamara, the question is, was school feeding offered in these schools? And if yes, how was that linked to the Alive and Thrive interventions?
Thank you, Sandy. Unfortunately, the schools who were implementing our program were not included in the school feeding program, so we are not able to come up with learnings in linking our intervention with school feeding program. But we are still working with the regional health bureaus to expand this lesson to schools where this school feeding program is being implemented. Thank you. Over to you.
Okay. And Tamara, I have another question for you, and I really like this one. And it's related a bit to the last question. Are school vendors available? Are they outside the schools? What do they sell? Why don't we stop there? But why don't you talk a little bit about the school environment and the vendors and interventions that may have impacted what was being sold to the students?
Thank you again. Yeah. Most of schools have the school vendors. Usually the school vendors, they sell sweets, especially in Somali. In some of the schools, they sell ice cream, in general, sweet candies and so on, cookies and so on. And some oily foods. So these were the type of food commonly sold there. And usually the pocket money the students have is not that much big, but with the limited pocket money, they usually prefer to buy those sweets. Again, this applies for SNNPR as well. So in relation to our intervention, we were trying initially, especially in the first phase or during the implementation phase, we were our intervention is not that much strong around influencing the school vendors. After realizing the findings from the inline evaluation, we redesigned our intervention, engaging the school vendors as well as adolescent girls and their parents, plus the local administration. During the initial phase, there was a lot of back and forth. We were trying to convince the vendors, but they slide back after making some adjustments, especially they were requested to sell fruits and vegetables, but as I said, they will maintain for some time and they go back to they consider the selling sweets and so on as the simplest one. So but now we engage in our redesigning, we engage the vendors, the Kabbalah administration, and the school administration, as well as the health, plus adolescent parents and adolescent girls. So under this, during our redesigning phase, we reached to consensus to hold a regular meeting with vendors to assess or to check their performance as well. And in addition, the school came up with simple school regulations that prohibit selling as well as consumption of unhealthy food. So such and similar type of intervention were in place. So these are the things that we did following. We did based on the feedback that we learned from the inline evaluation. Over to you, Sandy.
Great. And Tamara, could I ask you just very quickly to answer one more question? We have a listener who's asking about the contributions of school gardens to the diets of adolescent girls. So if you could just give us a quick answer to that one, that would be great. Great.
One of as one of the intervention, the ministry as well as the Warada school management is promoting, in addition, incorporating in our intervention was the school gardening. So yeah, initially, now it is a national program introducing school gardening in the school. So from this end, especially these days, when they are dealing with locally available food in relation to diversity, one thing they were considering is the school gardening. So school gardening is one of the way to show how they going to get vegetables to diversify their diet. Over to you, Sandra.
Great. Thank you again, Tamara.
Sandy,
Go
can
ahead,
I
Bonnie,
add a couple
sure.
of points to Tamrat's to complement what he has said on in terms of the vendors as part of the school assessments at baseline and endline. We had our enumerators walk a minute distance from the schools to identify the number of different food vendors. And at baseline, there were about just a little over half, about less than 60% of schools had some sort of a food vendor in 1 minute perimeter of the school, but at endline there were over 96% of the schools had a food vendor, and predominantly selling sweets, sodas, and fried food. So it really had the food environment is pretty important and prominent there, the other point is we did not measure on water insecurity, for instance, but we also know that this was a constraint in its water access or water availability in the school. So in terms of the food garden, so I think that might be a challenge, but it wasn't part of this intervention work. But I know that there's a lot of great ideas that are being expanded and learned from this initial work to enhance and scale up different interventions. Over.
Thank you, Sani. Purnima, is there anything you would like to add at this point about the food environment, school gardens, school lunch?
So many topics about food and not quite feeding, but food and food environments and adolescents, right? So I think there were some very interesting questions in the chat about, why didn't we see impacts on the consumption of unhealthy foods, for example, or, so I think this was, it was a shortish study done in some really very challenging circumstances. I think it was challenging for intervention delivery. It was also challenging for research, and it was, fairly tight on resources. So we didn't have an opportunity like we did in some of our other work in, in Alive and Thrive to do these extensive, studies of, qualitative studies on processes and, understanding the context quite a bit more. But I think one of the things that we're learning over, through the context of looking at other research on drivers of dietary choice is that we're going to, and this is, I think also sort of very clearly stated now in the Lancet Adolescent series, is we're going to have to go beyond in the intervention space. So the way that I think about it is that this set of Alive and Thrive interventions really focuses on the agency and some social norms, but there's other things happening in the food environment and actually even more seriously in the context in which food is consumed, not just what's available in the environment, but how do other structural drivers, such as what families have the ability to give their adolescents to bring to school, or how much money is available at hand for them to buy other types of snacks, etc. And what you're finding over and around the world is that many of these unhealthy snack foods, etc., are hitting the sweet spot in terms of convenience, time, really sort of sitting in a structural setting where adolescents are eating. And we have to work equally hard, maybe sometimes even harder, to reshape and, well, first to understand what that looks like, but then actually to reshape, those contours in a sense of the structural drivers of dietary choice. And I think we we just really have to, lean in quite a bit more on that. I think it's fantastic that there are these plans for scale up. And I'm really hoping that, in the context of that scale up, if there are opportunities to continue to do evidence building, either with Alive and Thrive or through other partnerships, or directly, if the government itself is able to do that, I think the nutrition community in Ethiopia and in other places will really learn so much more. So it's a very, very, very big agenda out there, to understand and to think about intervening around. So, it's great to have these findings because in a sense, they are great reminders of how important it is for us to focus on those structural drivers of some of these behaviors as well. Thanks. Thanks, Sandy.
Yeah, thanks, Purnima. And thanks for bringing up the issue about the agency of adolescent girls. And we do have a question about that. Dr. Abdulaziz, I'd like to start off with you, but invite our other panelists to also add on because it's such an important question. But the question we have is, what activities were used to build nutrition agency in girls? And also a secondary question about, did fathers have a role in improved nutrition practices? So we'll start with you, Dr. Abdulaziz.
Thank you. These are very great but difficult questions to really address. So with regards to inclusion of adolescent girls to these agencies, the important thing was from the beginning, as part of stakeholders, we consider adolescent girls as major stakeholders to this, and we strongly consider them, they are change agents in this process. So it's not only for themselves, even for their families as well. So we have used various platforms to reach out to them and to include them. So yes, though it's not really as expected, engagement of fathers was also there from the beginning because they were major stakeholders on this process, especially on improving the school environment. One of the areas where we need to strongly engage was the community and influencers, especially influencers on that area. So yeah, this is how we manage. Maybe at technical level, maybe if Tamrat has anything to address, Tamrat may add on this.
Thank you. The mentorship session is one of the opportunities that enabled adolescent girls to build their agency, especially in holding a discussion, to build their agency around holding their confidence, building their confidence, to hold a discussion with their parents. So that space enabled them to discuss among their peers how to discuss with their parents, to set a plan, achievable plan. For example, okay, I will go and discuss with my dad and my mom, and hopefully I will manage this aspect of the challenge and so on. They come back with something they achieved or some area that needs further support from their colleagues. So the peer session or the mentorship session is one of the things that enabled them to build the confidence or the agencies they need to hold a discussion with their parents. So this is especially one of the women, the mother was saying, this girl is behaving differently nowadays. Before, the woman is attending the parent meeting session because that girl was asking her to diversify her diet. So in addition, the home tech materials enable them to boldly speak about the benefit of adolescent nutrition for them. So these are the things that I can add. So over to you.
Great. Thanks, Tamara. And I think you also pointed to something I think that became obvious to us over time, that those adolescent girls were really becoming change agents with messages going back to the households and back to their mothers. Tina, anything you would like to add about adolescent girls as change agents or the whole issue of agency?
Yes, so we were quite intentional in finding ways to strengthen the self-confidence, self-efficacy, and agency of adolescent girls. And we thought this was a wonderful opportunity. First of all, in the classroom sessions, we encourage questions and answers rather than didactic lectures so that the voices of the girls could be heard. We encourage teachers to ask whether they were facing any constraints, even though they understood what the recommended behaviors were. We encouraged teachers to ask if they were facing any barriers or any concerns so that they could begin to voice their own ideas and experiences. Secondly, the BMI measuring session was intended to empower them so that they can take hold of what their situation is, so that they can become in charge of what was happening to them in terms of their height and weight and so on. Then they were trained as peer leaders. We strengthened their ability to converse with their peers. And the peer leadership was an important opportunity. Then, as was said before, carrying messages back to their parents kind of turned the tables. It wasn't parents telling them what to eat and what to do, but now it was the girls who had greater knowledge and greater confidence, and they were able to converse with their parents about nutrition. So these were just some examples. Over.
Great. And we have a question that seems to be brought up almost every single time we talk about the nutrition of adolescent girls, and that is, what about the boys? So Tina, could I ask you to continue on that thought, and maybe Purnima, you would like to add to it, or Dr. Abdulaziz? Thank you.
Yeah, this is a very good question. Boys are equally affected by poor nutrition and poor diet. So we are hopeful that by introducing nutrition into schools in this very proactive and action-oriented ways, not just imparting knowledge, but encouraging better dietary practices, that this would transfer over to the boys. There may be other strategies that would be necessary as well. And I think, this was a pretty short period of time that we had, and we wanted to focus on the highest priority for the government as well, and the data and the evidence showing that tremendous impact that adolescent girls' nutrition has for all members of society going forward. So I think one of the limitations also is that we could not address out-of-school girls. Now, this is a small proportion in Ethiopia, but also highly vulnerable. So hopefully in another phase, we will be able to do that. Over.
Purnima, anything to add?
No, not really, except to acknowledge the importance of it. I mean, there's lots of work to be done around in the area of adolescent nutrition. I think there has been a history of focusing on impacts on adolescent girls or interventions targeted to them, given especially, I think, a historical focus on nutritional challenges such as anemia. But in the context of many of the challenges that we're discussing today, including challenges that have been addressed in this, tackled in this set of interventions and in the Lancet series, I think there is, and there must be, a reckoning with the importance of tackling diets as a whole and for everyone. So having success with demonstrating success with one age group or one gender group in this type of intervention, I think should spur us on to being able to do this more widely. So I look forward to seeing Alive and Thrive do more on that.
Great, thank you. And we're going to let Dr. Abdulaziz have the last word before we wrap up, but I have a different question for you, Dr. Abdulaziz. I think this one is important. A participant noted the scale up by the government is quite impressive and wants to know, was the scale up strategy planned in the initial design from the beginning, or was it something that was added on at a later point? Thank you.
Thank you for the great question. Yes, it was planned from the beginning. I can say in Ethiopia 3.0 program, it is a system strengthening program where we work everything with the government as sustainability as a core issue. So when we started it, that was one of the important things, what can be really scaled up or sustained. So all the interventions we selected were, which we thought can be really scaled up in the government context. That's why we started with the existing platform, and the behaviors we changed it to do were less costly and can be scaled up. So yes, it was planned from the beginning to brief it. Thank you.
Great. Well, thank you. And thank you to everyone for joining us today for the webinar. And thank you especially to the Bill and Melinda Gates Foundation for funding for such important studies like these. As mentioned, we will be sending out the recording and the slides in the next few days. And on this slide, you will see we also have some publications and resources that are, some of them are relatively new. They are on our website. We just want to make you aware of them. I also want to thank the Alive and Thrive communications team for weeks of work getting this website ready, getting this webinar ready. And I think that's it. Please visit our website, and we wish you all an enjoyable rest of the day or your evening. Thank you.
Thank you.